Hello Biolight, turn off the alarm.
Ladies and gentlemen, greetings from Biolight headquarters in Zhuhai, People's Republic of China. Welcome to Biolight's conference on the clinical applications of regional oxygen saturation monitoring. You may grab your favorite snacks, your favorite drinks to sit back and enjoy this deep dive into this topic. My name is Dr. Saqib and I'm your moderator today. We also have our other three speakers, Dr. Hadir Hosana, Dr. Chandan Thakur, and Dr. Ahmed Allah. So let's welcome our first speaker of the day, Dr. Hadir Hosana. So this is Dr. Hadir Mohammed Hosana. She is the Assistant Professor of Pediatrics. She studied from Alexandria University, Egypt, and she is the consultant of Pediatric Intensive Care Unit. She is currently working at Alexandria University Children's Hospital and has published 10 academic papers, 51 citations, and she has an H-index 3. So it's all yours, Dr. Hadir.
Welcome, everyone. It's my pleasure to present to you today with Biolight about the regional oxygen saturation. We will talk about principle and technology in short, of course, physiological basis, clinical applications, and limitations. Regional saturation depends on the near-infrared spectroscopy technology, which is non-invasive optical technology, illuminate the biological tissue, which measures the intensity of light which has traveled through the tissues. Why infrared light? Biological tissue is relatively transparent to near-infrared light, while oxyhemoglobin and deoxyhemoglobin are the main chromophores in the human body that significantly absorb the light in the infrared spectrum. So the oxy and deoxyhemoglobin each have their own absorption properties that make them distinguishable by the near-infrared spectroscopy. By measuring the absorption in the specific range for oxy and deoxyhemoglobin, near-infrared spectroscopy devices are able to calculate the regional tissue oxygenation in the underlying tissue. But what is more important is the continuous monitoring using trends. Of course, this was provided by Biolight's monitoring using Basimo technology. And here we can find that all the time we are measuring the regional saturation from different body sets, mainly the cerebral or other organs. And what is more important is the trends, as we say, because it say if the patient is improving or is getting worse. It depends on emitting light and then read this light by detectors. The more light rays sent by the emitter, the better picture or the better reading from the detector. So it's maybe one ray up to 4 rays, but here in Massimo technology, it is 2 rays from each emitter, and then give us a full picture about the shallow and the deep tissue of the brain or other organs using this regional saturation. Where is the cerebral regional saturation? Because the sensors are placed on the skin and the depth beneath is the cortex depend on the thickness of the tissue in the light path, in the scalp and the skull, that need to traverse before getting to the cortex. So in both adults and neonates, light penetrates about 25 to 30 millimeter into the head, measured from the surface of the scalp. So in neonates, the thinner skull and the skin than the adult, this leads to the penetration to 10 to 15 millimeter in neonates, whereas it's only 3 to 5 millimeter in adults. The normal value of cerebral oxygen saturation in the neonatal brain range from 55 to 85%. Actually, the cerebral vasculature volume is made approximately from 75% from the venous side, which is the oxygen, representing the oxygen demand, and 25% from the arterial side, which represents the oxygen delivery. And the nearest measurements, non-invasive, near-infrared spectroscopy measurement, thus reflect the large portion from venous saturation. If there is a balance between oxygen delivery and oxygen demand, which is measured by the nurse. Cerebral oxygen saturation depends on the arterial side, as we said, which is the oxygen delivery part, and the venous side, which is the oxygen demand, and both will give us the idea about the cerebral oxygen balance, which is more important than only the oxygen delivery or only the oxygen demand. The balance between them is what give us the idea about the use of this oxygen by the tissue. The arterial oxygen delivery depends on arterial oxygen capacity and multiplied by the cerebral blood flow. Arterial oxygen content depends on the hemoglobin saturation, partial oxygen saturation, and the P50 of the hemoglobin. While cerebral blood flow depends on the cardiac output, mean arterial pressure, pH, and the partial oxygen and CO2 saturation, and using of inotrophs and vasopressors also will affect the cerebral blood flow. On the other side, oxygen demand depends on the cerebral oxygen consumption, which is affected by the state of consciousness, temperature, and drug used by the patient. So where we can use regional oxygen saturation devices? In emergency room, operation room, post-anesthesia care unit, in cardiac and intensive care units. All the time, clinicians looking for new ways to acquire useful information about their patient physiological status in order to provide optimal management, and it is the main goal for us in intensive care. Regional saturation will provide a non-invasive bedside monitoring of the cerebral and somatic regional oxygen saturation in pediatric patients. Infants are the ideal pediatric candidate for regional saturation monitoring, as nearly all the vital organs can be monitored by the light sensor placed on the skin surface. Pediatric clinician can interpret the regional saturation value in order to provide information about the perfusion, oxygenation, and metabolic status. And we said that it tests out, it gives us an information about the oxygen balance, how the oxygen delivered and how the oxygen consumed, and the oxygen balance in the tissue. So it gives us about information on perfusion, oxygenation, and metabolic status in the patient. Measuring regional saturation does not require a patient with acquired pulsatile blood flow. It not need pulsation, as in the pulse oximeter need pulsatile flow of blood, so I can read the oxygen oximeter. But in regional oxygen saturation, it does not need this pulsatile blood flow. So regional saturation complements the pulse oximeter monitoring of oxygen saturation. Since regional saturation does not require a strong pulse or a steady blood flow to function, so sometimes regional saturation used alone can also provide some oxygen level data in cases when pulse oximeter fail, because pulse oximeter depends on pulsatile flow. But if the streams are so cold or there is very, very poor perfusion in the periphery, so it bus exhibitor cannot read. But at the same time, regional saturation can give us information about the vital organs because it does not depend on the pulsatile blood flow. We use common site in children, forehead for cerebral regional saturation, abdominal for the splanchnic saturation, and the flanks for the renal regional saturation. And cerebral regional saturation has been most studied in use of practical compared to the other sites because the brain, as you know, that is very important organ. It can withstand hypoxia only for 4 minutes in children. More than that would be severe damage of the brain. It requires continuous oxygen supply and glucose and monitoring the brain directly to reduce oxygenation for the reduction of the oxygenation is potentially important in preventing brain injury. For regional saturation, the kidney is very important and had an important role in managing blood pressure and controlling the global tissue perfusion. So monitoring the renal regional saturation over the flanks is helpful to identify the low cardiac output state that traditionally vital signs or the cerebral regional saturation alone monitoring might miss this because the first organ to lose out to detect the low cardiac output is the splanchnic area, as we'll say after that, and the renal area. Also, the renal regional saturation potentially give a warning sign for acute kidney injury, which is a major problem in the pediatric intensive care unit. Splanchnic regional saturation, as you know, it will be potentially high value in the monitoring critical patient because gastrointestinal organs are often the first to suffer ischemic injury. Before anything, the blood flow to the splanchnic area will decrease. This means that the body will get the blood to the more important organs. So it is very important to use this splanchnic regional saturation. Unfortunately, it is not widespread use. And also, splanchnic saturation, regional saturation, may detect changes in perfusion status before the tissue damage set itself. So just the decrease in the perfusion will give an idea that will be a damage is coming forward. Splanchnic regional saturation had shown some usefulness to diagnose gastrointestinal specific disease like necrotizing enterocolitis in children, which is neonates. It's very common in especially preterm infants, and it can detect the occurrence of necrotizing enterocolitis just before happening, and this can help us to early manage to avoid complications. Some pediatric physicians have used NIRS to assess the degree of dehydration. So it can be used in ER and intensive care to detect the degree of dehydration in patients in the emergency room. They found that monitoring somatic regional saturation is in comparison with the cerebral regional saturation can determine quickly which patient require a bolus of fluid administration and the amount of intravenous fluid needed to achieve an euthymic status. So it's very important. It's a very common problem in pediatric ER. Also, multi-site regional saturation monitoring in pediatric intensive care unit can aid the early diagnosis and treatment of shock, cardiovascular, cardiomyopathy and myocarditis, trauma, cardiopulmonary resuscitation, and during return of spontaneous resuscitation process. It's very important time after return of spontaneous circulation after CPR. It's important to monitor vital organ saturation. Also, in congenital heart disease, it can differentiate between acyanotic and cyanotic heart disease. For the circulation in arterial state, is acyanotic congenital heart disease. Arterial saturation is more than 95%, venous saturation more than 65%, cerebral regional saturation more than 55%, renal regional saturation more than 65%. Compared to the cyanotic circulation, in patients with cyanotic heart disease, they have more risk for ischemia and hypoxia due to reduced oxygen supply. The arterial saturation is about 75%, venous about around 50%, cerebral saturation is more than 45%, and the renal is 55%. So it's more important during monitoring children with congenital heart disease, according to the it is cyanotic or acyanotic disease, give us the reference here. Also, during cardiac surgery, pediatric anesthesiologists have used the cerebral regional saturation to monitor the patient during the surgery, and it's very important to demonstrate that and this will lead to a better neurological outcome. It will give the surgeon, the anesthesiologist will give an idea to the surgeon when to stop or when to give fluid, when to give blood, because it's very important to protect the brains. So in pediatric and also in the pediatric cardiac care after surgery, it's important to monitor post-operative patients after corrective cardiac surgeries. If decreased cerebral regional saturation and the renal regional saturation are both decreased, this means there's a global oxygen delivery fallen or global increase in the oxygen consumption. As we said, this is either the problem in the oxygen delivery or there is increase in the oxygen demand or consumption. So to confirm with paired arterial and venous blood gases, it's very important. If there is increased consumption, we suspect to treat this by analgesia, sedation, cooling, paralysis to decrease the oxygen consumption. Or if there's a problem in decreased oxygen delivery, I will give blood transfusion, improve ventilation support, and cardiac output support by inotropes. Important notes. It's important to know that cerebral regional saturation less than 40 is associated with neurological morbidity. And 20% fall in the regional saturation value is significant, and the patient should be assessed carefully. The trend, again, the trend is more significant than an actual value. High values may indicate dead tissues, and this is important to know because the high value means that there is no consumption of oxygen. The oxygen delivered, but the tissue have mitochondrial disease or have mitochondrial failure, or there is a failure to consume this oxygen. So the value will be high in dead tissue. The limitations of using regional saturation is the accuracy. Most limitations are due to inappropriate sensor size and or placement of the connections. And I think in Biolight monitors, you have Massimo technology with different sizes of the sensor, which is very important to use the specific size, especially in pediatric age group and the neonatal age group, because there is a wide range of variety from neonates up to 16 years. All of these are pediatric. So we have to use a specific sensor, use a specific where the placement should be tied and in place, and the connectors to be sure that it is inside, and use easy connectors for that. And so the monitor will read continuously the saturation or regional saturation, what I need. Thank you for listening, and I was pleased to be with you now. Any questions?
Thank you very much, Dr. Hadir. That was a very nice presentation, and I think it was a very nice summary of all the comprehensive features of RSO2, especially for the pediatric department. So we have one question from the audience, which is, what RSO2 value would signify acute kidney injury? So I think this question is because there was a portion of your PowerPoint that mentioned RSO2 can be used for the detection of acute kidney injury or prediction of acute. So they want to know whether the value would increase or decrease.
Okay. In children, most of the problems is poor perfusion. So the most of causes of acute kidney injury in the intensive care is poor perfusion. So if the kidney is poorly perfused, this is the first sign to decrease the GFR global filtration rate, and then acute kidney injury will follow. So decreasing the flow to the kidneys, this indicates that there will be a problem. And usually in intensive care, we say that to prevent the problem is better than actual problem. So if we find that the renal saturation is decreased or the accepted renal saturation, this means that the kidney will going to have acute kidney injury. So you have to correct the cause, even to give fluid, to give blood, to do Doppler ultrasound to investigate the renal vessel flow if there's a problem as embolism or thrombosis. So I have to detect the cause. It gives me a red flag that the kidney is going to have acute kidney injury due to poor perfusion. But if there is actual kidney injury with damage of most of the kidney, more than 80%, it will give me very high, unexpected high regional saturation. This means that the renal tissues are damaged. So we don't want to reach this point. We really want to detect the problem early. When we find that the renal perfusion decreases than expected, then there will be a problem. I have to correct the saturation, because, as I say, monitoring in the ICU is number one to prevent the problems. Am I clear?
Okay, thank you very much for your answer. So as I understand, you said that because in the initial phases, we are just predicting, so the oxygen consumption of the kidney might increase initially. So we might see lower RSO2 values. However, once there is a significant damage to the kidneys, the values might increase rather than decrease.
And this is a bad omen, of course.
Okay. Thank you very much, Dr. Hadir. I will show your certificate, and this is a token of our appreciation. Thank you for being the speaker at our conference today.
Thank you very much.
Okay, thank you very much. So our next speaker is Dr. Chandan Thakur. Dr. Chandan, you may share your screen now.
Okay.
Yes, I can see your screen now. So this is our Dr. Chandan Thakur. His English name is Dr. Robert Peters. He's a specialist in respiratory medicine, and he's a graduate from Southwest Medical University. And he also studied pulmonology from Southern Medical University. And currently he is a consultant of and chest physician at AMDA Hospital. So thank you very much for being here, and it's all yours, Dr. Chandan.
Thank you, Doctor. Once again, hello to everyone. We all are talking about the regional oxygen saturation. So first, we must know the concept. What do we mean by regional oxygen saturation? So as we know, whenever patient landed in a hospital in emergency situation, we have very few things to monitor the oxygen. Mostly from COVID-19, we know the pulse oximetry. So first we must know what's the difference between pulse oximetry and cerebral oximetry. So as we know, the cerebral oximetry provides a direct method for measuring cerebral oxygen saturation. And pulse oximetry is a non-invasive, painless, and reliable method for measuring oxygen saturation, what we call the SpO2 in blood. So this pulse oximetry gives us value, what's the oxygen saturation present in our capillary. So now the concept has moved forward to the regional oxygen saturation. So regional oxygen saturation, that reflects the tissue perfusion, means what we are giving to the tissue, that's the pulse oximetry, the capillary oxygen saturation. And what the tissue is receiving from that capillary, that is known as the regional oxygen saturation. So as we know, whatever we are providing, we can see as in the blood vessel, there is oxygen and blood, hemoglobin, different content, and what's going in and what's going out. So what the receiving and what they are giving. So this concept we must know better. Now we can see, as here we can see, the blood is going here, but cannot receive the oxygen. Here, they can exchange a little bit. Here, they can exchange and receive better one, but here, no blood supply. So here, no gaseous exchange. This is known as the dead space. Similarly, it has got a concept in our emergency. A case like whenever a patient is brought in emergency situation to our emergency room, when there is no pulse, when there is no heart rate, no respiration rate, we go to the pulse oximeter, we do not know. So now, what's the oxygen level in the brain? What's the oxygen level in heart? So we start CPR. So when we go for the chest compression, airway, we have some oxygen parameter in our pulse oximetry. But what to our vital organs? Is oxygen going well to our brain or not? Is oxygen going well to our kidney, heart, well or not? So for that, now we need regional oxygen saturation. As we see, we have got this monitor. Everyone in the emergency department, they have got the pulse oximetry. So whenever a patient arrives, we quickly go for the vitals and we see the oxygen saturation. Okay, it's above 90. That means we think it's safe. But do we really know? Are our vital organs getting well oxygen or not? So to find that, this concept of regional oxygen saturation, that gives us a true value of the tissue perfusion. So now see, when we are going for the cardiopulmonary resuscitation, we go for the bag and masking. We go for chest compression. So now, what about our vital organs? So in many setup, they just depend upon the pulse oximetry, but that gives us just the capillary oxygen value, not the organ oxygen value. So for that, what we need to know, we need to go for the regional oxygen saturation. So now we can see a slide here. While monitoring CPR, we need to know the tissue perfusion in our vital organ, especially to our brain, heart, and kidney. So the most important goes to the brain, because within 3 to 5 minutes, they go for the temporal permanent death of the neurons. So now what we see here, usefulness of cerebral regional oxygen saturation monitoring during CPR to predict the probability of return of spontaneous circulation. So this study has shown that combination of regional oxygen saturation baseline with the amount of maximum rise in regional oxygen saturation value over the time might be a new index for the prediction of that our patient can survive back or not. So that could be useful in guiding cardiopulmonary resuscitation. As we talked before, during the CPR, we must monitor the value. So now how we can see the rise in the baseline oxygen saturation. So that gives a predictive value that the spontaneous circulation of patient will revive or not. So now we can see this has given us the value that differs from pulse oximetry saturation. Monitoring is that regional oxygen saturation data can be measured without the necessity of arterial pulsation. So now we don't need to wait for the arterial pulsation, that unless until there is no arterial pulsation, we cannot monitor the regional oxygen saturation. So this gives us a better value of measuring oxygen present in our vital organs. So now we see conjunctive and non-invasive pulse oxygen saturation may be measured using pulse oximetry, which allow for rapid identification of hypoxic state. Therefore, this technique is a useful clinical alternative to intermittent arterial blood sampling. Yeah, this is very useful when a patient has got their arterial pulsation. Then this capillary saturation can be measured. But the measurement of SpO2 has certain limitations and is difficult to use in the presence of just like nail polish, anemia patient, when there is a bright light, skin pigmentation, venous pulsation, and low perfusion. So as they may cause measurement error. So this is the initial step, but not the base. So what we see now, just like whenever we resuscitate a patient in emergency, give the CPR, now we need to transfer from emergency to ward, from emergency to ICU or intra-hospital transfer. So during the transfer, can we guarantee that patient vital organs are getting adequate oxygen or not? So this is the best way to know, even during transferring patients, we can monitor their vital oxygen perforation. So this is done by the regional oxygen saturation monitoring. So now we see whenever we are transferring the patient, we do not know what's the exact oxygen perfusion going to our vital organs. So regional oxygen saturation can be important and reliable parameter using in guiding and predicting the prognosis of patient, as they are the cumulative effect of many interplaying factors, hence are better predicted than other individual hemodynamic factor. So this regional oxygen saturation measurement gives us a better idea to the present scenario of critical patients. Now, this is the scenario of intensive care unit. So whenever the emergency doctor, they are working, whenever we enter the ICU, we can see this type of setup. Now see, on our monitor, one of our patients in our ICU landed up like this. So when I entered, we were puzzled. Several circuits, many monitor, so what to do? We are confused, what to check first, which alarm we should just like direct first, or which alarm we should address first. So at that time, we get completely confused as patient is critical, fighting with death. So if we have such monitor like this, infusion pump, the patient's vital monitor, anesthetic monitor, and in some scenario in emergency department, we need to do dialysis also. So dialysis, during the dialysis also need a monitor. So instead of looking for several multiple monitors, if we get a monitor at one place and at a glance, we can address what's patient problem, why alarm is on, what we should address first. So this is the quickest way a doctor can interact and help a patient to revive from the situation. So now, what this is what we say a plug or a sensory or infrared port from which we can measure the cerebral perfusion. So this value works as a deeper the penetration, better the result or better the value. So near infrared spectrometry based cerebral oximetry is a non-invasive technique used to estimate regional cerebral oxygen saturation. That extracranial blood flow is known to substantially affect regional saturation of oxygen value measured by most clinically available devices. So regional cerebral oxygen saturation measured by near infrared spectroscopy has often been used clinically due to its non-invasiveness and continuous measurement. So this non-invasive technique and infrared technique helps us to monitor beat-to-beat oxygen perfusion to our vital organs. And that helps us to immediately address the situation and continuously or quickly react to the condition. So we can see as its basis is on infrared technique. So as deeper the penetration, better the tissue perfusion value. So it has got one benefit that more the deeper, better the accuracy and better the prediction value, quick reaction and better intervention, early the intervention and better the prognosis. So now we can see this only do not provide us to measure our cerebral perfusion, but also helps us to monitor most of the vital organ of our body, and we can detect its early condition and situation. So these regional oxygen saturation provide information regarding regional tissue perfusion depending upon the site of a probe. So in road traffic accident case, or in CPR, or during the emergency situation, in shock, in every condition, we can monitor beat to beat our perfusion or deeper tissue perfusion, mostly of our vital organs. So this regional oxygen saturation monitoring could provide a bedside method that continuously and conveniently monitors real-time oxygen consumption. And that also monitors important tissue and organs, especially the brain, kidney, and intestine. So this gives us the real-time consumption value of oxygen and its perfusion. So now we see if we get multiple probes in a single system, so not only one organ, we can monitor multiple organ oxygen saturation at a time. So now see, this is what monitor we needed in our emergency, in our ICU, in our ward or high dependency unit. So whenever a doctor enters in a room to visit a patient, on a single monitor screen, we can see multiple different parameters, including the vitals, their peripheral oxygen saturation, their regional oxygen saturation, the tissue perfusion. So we don't need to click on the multiple monitor and we don't need to get puzzled what to address first. So multiple probe system on a single screen, single monitor, and we can address the situation at a single glance. So this is the best for a doctor to monitor different parameter value on a single screen. So thank you. Thank you for the time.
Okay, thank you very much, Dr. Chandan. There is one question from our audience. It's about hemorrhage. They want to know during traumatic brain injury, when there is brain hemorrhage, there might be some blood under the dura, subdura. So how would the RSO2 values be affected by that? And is it a good way to detect hemorrhage?
Yeah, okay, that's a good question. So again, thanks for the question. And yeah, if there is brain hemorrhage, so that won't affect its value because it's an infrared technique which measures the tissue perfusion. So in the brain hemorrhage case also, we can monitor the patient's real-time oxygen consumption by the brain tissue. So this is a good parameter to measure condition during the brain hemorrhage also. So it won't really affect the real-time oxygen consumption by the tissue.
Okay, thank you. I think the nature of this question comes from the fact that the blood is occupying the surface of the brain. So I guess maybe the values would slightly increase since there is a lot of blood right under the surface of the probe. Anyways, thank you, Dr. Chandan, for your time. Let me share your certificate. Thank you very much for your participation, and I hope that you would like to participate with us in the future. Thank you very much. Our next speaker is Dr. Ahmed Allah. Dr. Ahmed, are you there?
Hello, Dr. Saqib. Yes.
Hello, doctor. How are you doing today?
Hello, sir. It's all good, thank you.
Okay. Would you share your screen for us?
Okay, sir.
Okay, this is our Dr. Ahmed Allah El Edil. He's a specialist of anesthesiology, and he graduated from Mansour University as a faculty of medicine. And he's affiliated with Mansour International and is currently working as an anesthesiologist and an ICU consultant. So thank you for your time. Go ahead.
Hello and good morning from Egypt to you all, my respected colleagues. I am privileged to be among you today. For that, I have to thank Biolight Meditech Corporation. My fellow colleagues have fulfilled the regional oxygen saturation from pediatric and critical care points of view. So I am going to highlight the topic briefly from the anesthesia angle, especially cerebral oximetry. The maintenance of adequate oxygen delivery to the tissue and the organs, especially the brain, is fundamental objective of the anesthetic process. The dangers of prolonged hypoxia and reduced oxygen delivery to the brain are well documented. However, the brain remains one of the least monitored organs during anesthesia. We care about monitoring lung ventilation dynamics, flow volume loops, also cardiovascular system pumping action, cardiac output, blood pressure, and etc. But to a lesser extent, as anesthesiologists, we monitor CNS. So medical research had to come up with something continuously non-invasive monitoring device for adequate cerebral oxygenation, and it gives us values that represent the balance between oxygen delivery and consumption. Oxygen oximetry was the solution. So, what kind of operation that requires cerebral oximetry? In this slide, it's mainly major or long-standing procedure with major fluid shift, as in coronary artery bypass grafting, cabbage operation, valve replacement, aortic artery replacement with deep hypothermic circulatory arrest, liver transplant, ventricular assisted devices, ECMO, carotid endarterectomy, beach chair position in shoulder arthroscopy or frontal neurosurgery, neonatal cyanotic heart disease or high frequency ventilation or bowel ischemia. Questions have been raised with regard to clinical utility of cerebral oximetry monitoring. An increasing number of studies are demonstrating the ability of cerebral oximetry monitoring to detect clinically silent episodes of cerebral ischemia. Cerebral oximeters have the potential to be an important safeguard for cerebral function. Under general anesthesia, anesthesiologists sometimes faced with neuronal dysfunction or even death. This can happen on a daily basis with neurosurgery anesthesiologists. Measurement of cerebral oximetry by near-infrared spectroscopy provides a continuous and non-invasive information about oxygen saturation of hemoglobin in central nervous system. This is especially important in the case of patients with TBI or traumatic brain injury. Continuous bedside measurements help in identification of episodes of cerebral hypoxia and rapid diagnosis of intracranial. Intracranial bleeding or cerebrovascular autoregulation disorders that lead to accelerate the implementation of treatment. Sorry, the slide just move forward. So, treatment of patients with TBI is focused on preventing secondary brain injury. For many years, the standard care of TBI patients has been the monitoring of IC intracranial pressure and cerebral perfusion pressure, alongside with continuous electroencephalogram. However, this method doesn't provide direct information on hypoxia and ischemia, or even the metabolic needs in the brain tissue. So, there is a need to use a method that allows the assessment of cerebral oxygenation. Regional oxygen saturation, especially cerebral oximetry, is increasingly employed in the therapy of TBI patients as it fills a gap that no other monitoring devices can. So there is a balance, or there is a need for neuroprotection and neurodetection. CT, echo, EEG, and the MRI are late indicators that doesn't help us in these conditions. So no real-time bioassay to detect the onset of brain injury. And that's the role of cerebral oximetry. Here is the methane module of regional oxygen saturation used in Biolight monitor, in P1 monitor. So in brief, in physical principle for the cerebral oximetry, according to Pearl-Lambert law, which is absorption in Lambert states that absorption of material is directly proportional to its thickness. Here we are talking about the concentration of light waves from the emitter that travels through skin, scalp, and the brain tissue, and back to the detectors or the receivers to be calculated. In August Peer, there is attenuation in relation caused by the concentration of the material itself. So what is the difference between pulse oximetry, or mean difference between pulse oximetry or regional oximetry? For pulse oximetry, they are both using Pearl-Lambert law. Both are based on Pearl-Lambert law oximetry. In the case of pulse oximetry, it's only two wavelengths using light loss, systole and diastole, to calculate only signals due to pulsation, blood to drive arterial oxygen saturation. On the other hand, cerebral oximetry are looking to the entire non-pulsatile field to drive tissue oxygen saturation. It requires more wavelengths to account for the light loss or other elements, as in melatonin, in addition to oxy and deoxyhemoglobin. So what is the component? Simply, it's component from one emitter to detectors or receivers. It goes like a banana-shaped waves from the emitter to the receivers, and the information get back and calculated or interpreted by the module itself. So how it works? Light travels from the sensor light emitting diode to either proximal or distal detectors, emitting separate data processing of shallow and deep optical signals. And that's our point of concern. Differences in absorption of the spectra of deoxy and deoxyhemoglobin allow measurement of relative changes in hemoglobin concentration through the use of light attenuation to multiple wavelengths. So, all technologies uses only two wavelengths with no absolute normal value, and their algorithms are only designed for adults. Their interpretation was difficult, and the normal value was debatable. Also, there was no trend graph display. That was back in 2006. So, over the years, there was a continuous improvement to numbers of detectors, variety of wavelengths emitted, shallow and deep, as we mentioned before, and the trend graph display that led to increase the module accuracy. On the right picture, the old technology of near-infrared spectroscopy, they use only two channels and with accuracy of around 9%. Recent technology of near-infrared spectroscopy using 5 channels, and their accuracy are raised to about 97%. Here is the P1 series from Biolight that allow deep tissue monitoring in addition to providing complete monitoring solution with trend graph and the smart alarm. We here can also see that is complete from the point of neuromuscular transmission from the regional oxygen saturation in electroencephalogram, anesthetic gas flow, carbon dioxide and bispectral index, respiratory mechanics, impedance cardiography, and the invasive, also cardiac outputs. This is a maintenance tab of the balance anesthesia, also in D1. It displays the trends of the parameters, including the trends of regional oxygen saturation. Below, you see a triangle. It is the anesthesia status indicator. The anesthesia status indicator is green and full when parameters are within the normal limits. If parameters are outside the limit, bar will decrease and become red. So move away of the center and become red. If the parameters are higher than upper limits or lower than lower limits, so there is imbalance in anesthesia. For the anesthesiologist, this will make their life easier. This is a very good limitation and how overcome it. Our proposed algorithm for the intraoperative use of cerebral near-infrared spectroscopy in seminars of neurosurgery. So we are using here an 8-step approach for determination of cerebral desaturation and how to overcome it. Number one, specify if cerebral oxygen desaturation, we verify the head position, which is one of the limitations of using it. So we can redirect the detectors, and if the desaturation session is ended, so reposition and everything will be okay. If it doesn't, so we depend on the mean arterial blood pressure to find the etiology. Then our third choice, if sustained desaturation, we come for the mean arterial blood pressure for the systemic saturation. So if it's abnormal, so we treat the etiology. Fourth step, if the systemic saturation is normal, we go for the dioxide, carbon dioxide, to correct with hyperventilation. If it's normal, fifth step, we choose hemoglobin, anemia, to consider red blood cells transfusion. With normal hemoglobin, sixth step, we come forward to the cardiac function and the venous oxygen saturation. If it's below 60%, so hemodynamics and the echocardiography evaluation to optimize cardiac condition. And if cerebral oxygen consumption is normal, so it is increased in cases of hypothermia, or cause of hyperthermia or convulsion. So we treat the cause with the hypothermic measures or anti-epileptic medication. Last step, we choose if there is sustained increase in intracranial pressure. So there is a cerebral imaging or the CT or MRI to reduce brain tension. Here is an interesting morbidity statistical review. Approximately 465,000 cardiopulmonary bypass surgeries performed in US each year. Cerebral desaturation occurs in 17 to 23%. Adverse neurological outcomes occur in 6%. So, goals in the past were limited to just to maintain oxygen saturation to 100%, maintain bench at normal intensity. But desaturation can occur with normal value. So maintain brain perfusion to prevent post-operative complication. This can be done by regional oxygen saturation and its early detection. Thank you for your time.
Okay, thank you very much, Dr. Emmett. Actually, there are two questions for you. The first question is, what kind of patients do you recommend to use RSO2 during anesthesia or surgery?
Well, it is depend on the patient and the operation itself. So we talked in our slides about the major operation with major fluid shift, long-standing procedures. We just mentioned them. This is a type of operation. Patient itself, general condition, comorbidities, especially اللي هو cardiac or cyanotic heart disease in pediatric, post-op and major exploration surgery in the department of ER. Yes.
Oh, okay, I think you already answered the second question, which was what age group would you recommend it for during surgery? So I think you already answered that question in your first answer.
Yes.
Okay, thank you very much. I am going to present you your certificate for your participation today.
Okay, thank you.
Here is your certificate. Okay.
Thanks.
Thank you very much. And thank you everyone for being here. We will share your certificate to you by email. And okay, I think I'm going to wrap up and summarize by talking a little bit about our monitor and some of the features we have. So give me a second. So I'm going to be talking about the high-end parameters of our Biolight P series patient monitor. So the picture you see is for our P22 monitor, which is a 22-inch monitor. So as Dr. Ahmed also described, we have a couple of parameters such as NMT, RSO2, EEG, and even bispectral index, and quite a lot of parameters that you might be viewing in the OR, in the ICU, in the emergency department. Right. So this is our RSO2. This is our module. So every parameter that we have, some of them are like some monitors, they have them built in or so, but for us, most of them are modular. So you can plug in, plug out, you can plug it into another monitor and use it over there. That's very easy. And you can see here we have the sensors, the sensor 1 and sensor 2 that you can place on different parts of the body. So basically, if I summarize RSO2, it's a device that ensures the oxygenation of tissues, especially the brain during surgery, CPR, or in the ICU. And the purpose of this device is to help prevent tissue damage. It helps visualize resuscitative efforts. Right, we also have this NMT device. I'm not going to go over them. I'm just going to show you what the devices we have. Bispectral index, respiratory mechanics, and EEG, which we have our DSA, the multi-taper spectral analysis, and EEG, which we know what the function of this device is, and non-invasive methods of cardiac output monitoring, like impedance cardiography, ICG, and invasive methods also, like this one. So this is with the Swan-Ganz catheter. And then we have a lot of non-invasive parameters by Massimo Rainbow, which are all calculated by. So as you can see, we have perfusion index, pleth variability index, carbon monoxide, hemoglobin, methemoglobin, and total oxygen content. All of this is being acquired from a pulse oximeter. And then I'm going to show you some clinical assistive applications. So this is our sepsis view. This covers all the sepsis guidelines. If you are in the ICU or in some other department where you need to monitor patients for sepsis, this presents the 2021 sepsis guidelines for adults. And very soon we're going to be working on the guideline for pediatrics. This is the balance of anesthesia view that Dr. Ahmed also introduced. This is the EWS, which is a early warning score, and the one you're seeing on the screen, this is the News 2 score. We also have News 1 and Muse as well. This is GCS score. This is an RS score. I think this is something new in a patient monitor. You might have not seen this before. This is a visual assessment score or numerical rating scale over here. So the patient can choose how they feel, or they can tell you what to choose based on how much pain they have. And this is mostly for either post-anesthesia care unit or ICU. And we even have graphical charts for them. So you should be able to monitor the trends. And a new feature coming up is the call score. So thank you for your attention. Thank you for your time. If you have any questions or you have any queries, please contact us at, so if you have clinical queries, please contact us at drsakib@blt.com.cn. And if you have any business inquiries, you can ask us at overseas@blt.com.cn. So thank you for your time. Thank you for being here. Thank you, everyone. Thank you, Dr. Chandan. Thank you, Dr. Hadir. And thank you, Dr. Ahmed. Have a nice day.
Yes, we will do. Thank you very much.
Thank you.
Thank you, Dr. Sar.
Hello Biolight, turn off the alarm.